Good morning, all around the world. I hope you guys can hear me. Somebody check in with me. Hey, Cheryl Cofield, how you doing? Can you all hear me? Okay. Just want to make sure. If you can hear me, somebody give me a thumbs up, please. Hey, Cindy. Good morning. Hey, Okaza, how you doing? Um, okay, you got me, Cindy. Thank you so much. I appreciate it. Awesome. Thank you all so much for joining this morning. You are on with Hanging with Dr. Cooper. Live from my little apartment studio in Kansas City, Missouri. How's everybody doing? Give me an update. Let me do some shout outs. Cheryl Cofield, Bubbly Brown Sugar. Hey there. How you doing, young lady? Long time. Okaza Brown. How you doing? Checking in. Hey, Sherry. How you doing? I see you up there on Facebook. Thank you so much for joining. Zo. I'm not sure of all the handles. So if I don't, hey, K Love, how you doing? Good to see you. Uh, I don't know all the names on the handles, so you all bear with me on that one. All right, just doing some shout outs. You're hanging with Dr. Cooper. We're going to talk a little bit this morning about Commotio Cordis. Commotio Cordis is supposedly the condition that the young man, the NFL player Damar Hamlin, suffered during the football game. So we're going to talk about a little bit about Commotio Cordis, but really the issue is that's just a terminology for a traumatic cardiac arrest. And so the real subject is talking about cardiac arrest. And so that's going to be our topic today. Got a few people over there on YouTube. Thank you so much for joining in. I think I'm going live I'm live on LinkedIn, Twitter, YouTube, Facebook, my personal Facebook page, as well as the Dr. Coop MD Facebook page. Hey, Crystal, how are you doing? Long time. Hope all is well in your land. Hey, Miss Sasha LaRue. You know I know who you are. Good to see you. I hope everything is well with you. All right. Chillin' Dot. Hey, how's it going? What's happening up in Martha's Vineyard? All right. Just doing a few shout outs right now, hanging with Dr. Cooper. Today, we're going to talk a little bit about Commotio Cordis. Again, Damar Hamlin suffered that very scary, really traumatic, something really intense to sort of see event. And so we'll talk a little bit about that. But the real issue is cardiac arrest. And what are some of the issues related to that? This is Heart Month. February, not only Black History Month, but also Heart Month, where we basically highlight the importance of heart disease awareness and understanding your risk, also understanding what you can do about it, understanding how to prevent it, understanding that the power is all in your hands. So with that, let's get started. Okay. Commotio Cordis. Hey, Melanie, I see you. I'm going to give out some, y'all know I call people out, and I appreciate you all for checking in with me. So Commotio Cordis is, again, I haven't seen the young man's medical records. It's not my business, quite frankly, but that is, hey, Dr. Keisha Davis, how are you doing? Hey, hi, Michaela, how are you doing? Michaela Lynn's checking in. So the condition that reportedly the young man suffered was what we call Commotio Cordis. So what is that? That's just another fancy medical term for essentially a traumatic induced cardiac arrest. The reality of it is that it gets attention because it is typically seen in otherwise healthy young athletes who are participating in contact type sports. Football, luckily, is not, quite frankly, high on the list of sports in which that is a problem. Actually, it's reported, according to some of the data that's out there, it's basically a little bit more common in sports like baseball. And you can imagine getting hit. There's no protection in baseball on your chest unless you're the catcher. Getting hit right in the chest, right over your heart with a baseball at 80, 90 miles an hour. And that could be really, good morning over there. How you doing? That could be really, really problematic. Okay. Hey, Donna, Sherry, how y'all doing? I see you. Melanie checking in. Thank you all so much. Hey, cuz, how you doing? Dr. Mohair, good to see you. So the Commotio cordis, although everybody's, I mean, it's pretty shocking to see someone go into cardiac arrest. It's what I do every single day, and so uh, we see this all the time. But it's very shocking to people who have never seen that, and also to see it in an environment where it just seems completely out of place. And so that is what we're going to talk a little bit about. So what actually happened with this Commotio cordis? Okay. Again, it's a traumatic impact to the chest at a very specific time. Now, assuming that the person's heart is otherwise normal. Now, if you don't have a normal heart, getting hit in the chest could be a problem because of the problem with your heart. Okay. But assuming that the person is otherwise normal, okay, and the heart is otherwise normal, okay, what happens is you get hit, or that impact occurs at what we consider a vulnerable time in the cardiac cycle. Okay. Now, what is the cardiac cycle? You all know you're hanging with Dr. Cooper. I try to keep it real. I try to keep it in your terms. This is not for doctors. This is for you. So the cardiac cycle, essentially, the heart is a very complex organ, but you just think about it like this. The heart has a very complex circuitry. Okay. So when we talk about, the cardiac cycle, okay, we are talking about the impulse or the electrical impulse, literally, that is created in what we call the sinoatrial node, which is up what we would call the top, but it's top, saying it's at the top of the heart. It's really at the top of the cycle. Is kind of a misnomer because anatomically that doesn't make sense. But you have what we call these nodes. And just think about the node as sort of like a transistor in an electrical system. Okay. But it actually creates that impulse, electrical activity. It then goes through the upper chambers of the heart. Okay. It then goes through another relay point that we call the atrioventricular node. Okay. Another large area where a lot of stuff comes together in one place. And then from the AV node, it then gets basically amplified and then transmitted through the lower chambers of the heart, the left and right ventricle. Okay. And so that is the electrical impulse that creates the beating of the heart. Okay. Stimulates the muscle on the top of the heart to squeeze. That is then coordinated through the AV node. When it gets amplified, that signal it all comes back together at the AV node. It gets amplified again, gets sent back out. Now the ventricle beats. So that's why you get the rhythmic boom, 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 upper chamber, lower chamber. Okay. So it has to have a stimulus, which is naturally occurring involuntarily through the sinoatrial node. And that electrical impulse basically just travels through the entire cardiac muscle very smoothly. Okay. Now, the end result of that is to make the heart beat. The upper chambers squeeze, the lower chambers squeeze. Okay. That squeezing we call systole, meaning to squeeze the blood out of the chamber. Okay. All right. So we're completing the cardiac cycle. All right. And then what has to happen in a very, very short period of time is the heart has to relax. Okay. We call that diastole. Okay. That is the period of filling of the heart with blood. Systole is a period of ejecting the blood out of the heart. Okay. Every time that happens, we're talking about a complete cycle. Okay. Got it? Somebody asked me once, why don't you use props and all that? No, because I want you to listen. Okay. I don't want you looking at slides and pictures and videos and, shit rolling all across the screen. No, you need to listen to what I'm telling you. Okay. Hey, oh, wait, we got one of the world's experts in the house, J. Mario Powell's over on LinkedIn. Hey, my brother, how you doing? He was quoted widely, as a matter of fact, he's an interventional cardiologist and was quoted widely on this issue of Commotio cordis during the period of time where this was a really hot topic. Okay, so let's get back to what we're talking about. Talking about the cardiac cycle now, okay, and this whole idea of Commotio cordis. So you've got the electrical activity, all right. Just imagine that, okay. that you've got this really powerful impulse that's going through the upper chambers, now the lower chambers. Okay. And that electrical system, okay, is fairly, and again, assuming the heart is normal, otherwise, there's no scar tissue, there's no other sensitivities to the heart or whatever. So it's just going about its normal business. Okay. And then all of a sudden, okay, you get this impact. Okay. Now you'll say to yourself, okay, well, boxers, they get hit all the time. Football players, basketball, there's soccer, all of these. So why is this not happening? Okay. And here's why it's such a rare occurrence. Okay. Remember, I talked about the cardiac cycle and that electrical activity. There is a period of time in there, in that cycle, where we consider the heart to be very vulnerable to a secondary, okay, electrical sort of stimulus, if you will. Okay. And that electrical activity, just so you have an example of what we're looking at. When you go to the doctor, and everybody's familiar with the proverbial EKG, that EKG, electrocardiogram, is basically simply just measuring the electrical activity that's basically propagating through your heart muscle. Okay. So when you see the first little bump, that's called a P wave, that correlates with the top of the heart beating. Okay. And then you see a little bit, almost like just a little flat line. Then you see a boom, boom, boom. We call that the QRS. Okay. And then you see it drop back down to baseline. Okay. So the P wave is when the upper chamber beats. The QRS is when the lower chamber beats. Okay. That's why typically in a normal circuit, they're pretty close together, the P wave, and then you get the big QRS, the big thing that looks like a lightning bolt going through the EKG. All right. Then it comes back down to the baseline. There's very low level electrical activity at that point. Heart's now relaxing. And then you get another little jolt, which is called the T wave. Okay. That, ladies and gentlemen, just think about that as a recharge. Okay. It's a way to think about that T wave as a recharge. If you were to get another huge electrical stimulus at that period of time, we consider that a vulnerable period. Okay. Because the heart's relaxing, it's creating this electrical energy. You remember now the heart's moving, you got an anatomic structure. So it's relaxing. You get this little indication on the EKG. That period of time, if you try to now go and boom, hit that again, you're going to end up potentially creating a chaotic electrical storm. Okay. So just imagine, example. Okay. You're sitting in your house. Okay. Boom, you hear the thunder, and then you see the lightning and the lights in your house flash. So you imagine on a very, quite frankly, similar scale, if that impact occurs right there, it's in a vulnerable situation, and it could potentially lead to now a chaotic, discoordinated, completely out of sync electrical activity going everywhere. Okay. That is a problem. Okay. Because what that would look like on an EKG is a bunch of just disorganized activity. Okay. And we call that ventricular fibrillation. Okay. That is not compatible with life. Okay. It can basically degenerate into complete cardiac standstill if you don't act upon it very quickly. Okay. To defibrillate. All right. Basically deliver another blow or another electrical charge to basically get the heart now sinking back in rhythm. When I first started out in heart care years ago, there was it used to be a part of ACLS protocol, the cardiac thump. And I had never been more impressed, at least at that point in my career. I was on rounds at Emory University Hospital. I was on the cardiac service and making rounds one Saturday, and he wouldn't mind me saying this. we're making rounds with Dr. Joe Craver. And if any of you from Emory know Dr. Joe Craver, he trained me, was one of my professors there. Joe's this big, football playing guy, played at UNC in North Carolina, just gruff, kind of, big old boy. So Dr. Craver, we were making rounds, and literally in the ICU, we had a patient literally go into ventricular fibrillation. And I was like, and so of course, everybody, he's in a cardiac intensive care unit, everybody sort of kicks in, okay? And Dr. Craver said, get out of the way. Get out of the way, let me get in here. Dr. Craver literally came in there and boom, right in the middle of the chest. I'd never seen anything about it. I said, is this dude crazy? What is he doing? Of course, I knew about a cardiac, thumping the heart to try to get it synced back up. But, just at that point, you're not kind of thinking about it. You kind of like nurses are trying to get them hooked up. You're trying to get them shot. Dr. Craver, get out of the way. God damn it. I got it. Boom. And hit this guy square in the chest now where he just had open heart surgery. Sure enough, the guy's heart paused for a second. Everything stopped. You got a flat line. And then all of a sudden, his heart started beating again. I was thoroughly impressed as a young whippersnapper who's just starting out on this heart surgery journey. I was like, oh my God, did he just do that? So you imagine if you're standing there, you're just like, oh my goodness, and he knocked the living crap out of this man, but that man lived because of the quick action that he took. So essentially what he was doing is the reverse of what, potentially the Commotio Cordis in the case that we're talking about with Hamlin started. He basically reversed with another huge impact. And those impacts can stimulate the electrical system in the heart. Essentially, you throw everything into standstill, and then you allow the normal system to kick back in. So you all have seen that. I mean, you've been on airplanes when they say, oh, we got to reboot the engine or reboot this or reboot that. So that's kind of what's happening in that scenario. Let me give a few more shout outs. You're hanging with Dr. Cooper. We're talking about Commotio Cordis. We're going to get to talking about cardiac arrest. We're basically in there now. Shout out to my good buddy, Dr. J. Mario Powles, MD, checking in. Mark Hayes, my man, Mark Hayes. How you doing, bro? Donna Owens, I see you. Appreciate you. Hey, Nira, how you doing? Neighbors in the house. Good. Thank you so much for joining us. Joanne Borders, how you doing? Carol, I see you. Okay. Hope all is well. I'll shoot you a message later. I see, we got Coop joined on Instagram. Coop is my son, Junior. Hey, man, how you doing? I hope I'm spitting a little knowledge, to your satisfaction. Okay. So anyway, that's what we are talking. We're talking about Commotio Cordis and cardiac arrest. So I hope you understand that. If you have a question or comment, put it in. I know we can do it on Facebook, LinkedIn, Instagram. I think you can send me a note as well if you want to comment. If I don't get to it while we're here talking, I'll talk about it. I'll try to answer you a little bit later. So for all of the parents, let's just move on from this. Let's talk a little bit more about this Commotio Cordis. For all the parents out there who are concerned about this, no concern. Okay. This was a very, very rare event. I think there's only been one. Well, let me just, I don't know that. I mean, Damar Hamlin is with us. Okay. And he's with us because of the very swift action of the people that were there on the field. So we'll talk a little bit about what needs to occur in that setting. But just now, parents don't worry about this. Don't need to go out and get your kids checked for Commotio Cordis. It doesn't make any sense. Okay. You need to go and obviously do all of the normal things that you would do from a physical examination perspective when you're going to participate in a physical exercise program for those of you who are not athletes, but also if you're going to go into sports. And what are we listening for? Typically what you're listening for, what doctors are listening for on young kids who go through to have these sports physicals, they're listening for a heart murmur, okay? Because that could be an indication of probably one of the things, probably the most dangerous that can be subclinical, and we don't know that a child has it, is called hypertrophic cardiomyopathy. Not going to get into that. Maybe I'll bring one of my experts on to talk a little bit about that over the coming weeks. But just suffice it to say, the doctors are listening for a murmur. They're making sure that the rhythm is normal and just an overall general physical examination. Okay. So that's what you need to do. I wouldn't worry too much about my kid getting hit with a baseball or, taking them out of sports or anything like that. Now, here's what is very interesting to me. And I don't know the answer to this question. I've looked and I've heard a few so-called experts talk about it, is whether or not DeMar can ever play again. So we don't have any data to suggest that if this happens to you once, it's likely to happen to you again. Okay. Don't know the answer to that question. So the only thing we can do is extrapolate the data we have from any kind of cardiac arrest to this. Okay. So that's what the Commotio course. And I'll refer back to this case or what happened to DeMar Hamlin frequently as we go through this, because I think it's important to understand. Okay. So that's the theory behind what happened. And so let's talk a little bit about some of the other causes of cardiac arrest. Okay. Cardiac arrest, essentially the heart stopping, going into an abnormal rhythm, one that cannot sustain life, ventricular fibrillation, an SVT that you can't perfuse. Your heart's going way too fast. Number of different causes for that. Probably the most common thing that we see is someone who has cardiovascular disease, blockages in the arteries. What happens? You get, you basically reduce blood flow to various parts of the heart, even if you've never had a heart attack. And that can become scar tissue over time. That scar tissue within the heart can also lead to some abnormal rhythms being deflected or electrical activity being deflected in different directions. Things get chaotic, you go into cardiac arrest. Okay. So that's one of the causes is cardiovascular atherosclerotic disease. Okay. There are also some other types of cardiomyopathies. I talked a little bit about infiltrative cardiomyopathy, where you have essentially sort of fibrosis of the heart. Hypertrophic is one of those to some extent. That's one. Some really weird things. Amyloidosis, sarcoidosis, those kinds of things can affect the heart muscle. Those are the more rare things. The more common things are the physiologic blockages, okay, and structural problems with the heart, okay? Now, it's not that those things just, alone cause it. It's the dysfunction and the stress that it causes on the heart, okay, that can lead to that, okay? So any kind of valvular problem, aortic stenosis, aortic insufficiency, mitral stenosis, mitral insufficiency. What happens over time is as your body adapts to those conditions, it does several things. It can do several things. In the case of what we call aortic stenosis, where the aortic valve tightens up, the heart muscle thickens, okay? And so when that happens, the little blood vessels from the surface of the heart have a hard time getting to the inside of the heart to deliver oxygen. So any condition, all right, and that's one example, where you have a reduction in oxygen flowing into a particular part of the heart, you can end up being vulnerable, okay, to ventricular fibrillation, ventricular tachycardia, sudden cardiac death, meaning your heart just stops, okay? So it's typically a lack of blood flow, an electrical issue, a stressor on the heart, or a remodeling of the heart that's abnormal, okay? In the case of congestive heart, the aortic insufficiency, where the valve leaks, okay? And blood is it's like a washing machine. Blood's just going out, coming back in, going out, coming back in, okay? And what happens over time with those patients is the heart dilates up first, okay? It starts to stretch out to do what? Accommodate all of that extra blood that's coming back in. So when you start to stretch the muscle fibers apart, what goes in between those muscle fibers is scar tissue, okay? That's why it's very, very important to kind of get on top of that, because if you can arrest or stop, no pun intended, but if you can stop that process, you can preserve heart function long-term. Important. How do you do that? Well, go to the doctor and get checked out. I mean, I'll keep saying that, okay? So that you understand what your vulnerabilities are. You'll hear people that have congestive heart failure, okay? One point about congestive heart failure, I did a talk with my good friend, Dr. Tara Rabowski, who's down in Florida, transplant heart failure doctor, is that, remember now, heart failure is not necessarily in and of itself a diagnosis, okay? Heart failure needs to be it's a syndrome, it's a constellation of things: swelling, shortness of breath, heart weak. So, and you can also have a heart that's basically normal function, okay, where it doesn't relax very well, okay? And so you got to be, you really just, when a doctor tells you got heart failure, you need to be asking one simple question: why? What caused it? Okay? Sometimes we don't actually know, okay? One of the probably most common silent kind of things that people develop heart failure from is high blood pressure that's either undertreated, untreated, or basically completely out of control. So high blood pressure, think about that. Okay, so we've got all of these various causes potentially of creating a cardiac arrest situation. All right, heart attack. You block off an artery on the heart, and I'm telling you, there's just a cascade of events that occur in those situations. Okay, not only is that muscle dying or infarcting, okay, it's now, just imagine all that electrical activity I just talked about. Okay, it's affected by that, can't deliver any more electrical charges into that area, becomes very dysfunctional. Okay, and so that can lead to a cardiac arrest. All right, so got all these things out there. So basically, any condition, underlying condition that creates a physical or anatomic stressor or electrical stressor on the heart can lead to cardiac arrest. Okay. All right. So when we think about the heart stopping in these situations, okay, what do you do about it? Okay. Well, first and foremost, I just want to implore everyone, this is Heart Month, to get some basic CPR training. Okay. Very, very important. Okay. Just to do some basic CPR training, whether you get it at your church, your fire station, police station, wherever you want to go, your schools, everybody should know something about doing CPR, if nothing else, but how to pump on someone's chest when that occurs. So what are you concerned about when someone goes into cardiac arrest? There is a time dependent thing going on here. The most vulnerable organ, quite frankly, when the heart stops pumping blood, is not the heart itself, is actually the brain. Okay. So that's why time is of the essence. You can literally, we, see patients all the time who, we operate on, who haven't had any blood flow to parts of their heart for hours. And we're able to restore that blood flow with stenting or heart bypass surgery or whatever. It actually improves. Okay. Not the case with the brain. Okay. So the immediate concern for someone who goes into cardiac arrest is oxygen to the brain. And so that's why all of the CPR, ACLS, advanced cardiac life support protocols talk about the airway. Why? Because you got to get air in, okay? Breathing, because you got to bring the oxygen in. All of that is designed to basically protect the brain, all right? Second to that, okay, is restoring the rhythm, normal rhythm back to the heart as quickly as possible, because you want to be able, the heart to be able to pump to get that blood to the brain and all the other vital organs, kidneys, liver, spleen, pancreas, intestines, all of that is important. Okay. So restoring normal rhythm is the most effective way to treat a cardiac arrest, a sudden cardiac death. Now, it gets a little complicated. Okay. Now, we talked about the ventricular fibrillation. If that's occurring, okay, then you can defibrillate that. You can knock that back in the sync. But what if the heart just stops completely? Okay, what we call asystole. Okay, all right. You may see on an EKG, if you happen to be in that situation, you may see the EKG look completely normal. Electrical activity is going through, but the heart itself is not pumping. All right. That's why CPR, when somebody goes down like that, you won't know that until you're able to hook up an AED or get an EKG or something on the patient so you can actually see that rhythm. Okay. But it's very important, regardless of whether you're in asystole or whether heart's, just ventricular fibrillation, to basically restore normal pumping as quickly as you can. All right. The asystole could be a big problem, because then you've got to basically either pace the heart, artificially cause the heart to beat, or you got to continue that CPR until the heart decides to kick in, or you can give some kind of medication that's going to make it stimulate it to actually beat on its own again. Okay. So most important thing is immediate CPR, so you can restore airway, make sure they're breathing, make sure you can get some oxygen, and start that pumping on the heart, because that's going to preserve brain function, which you only got a couple minutes, depending upon, what's going on inside your head to do that. Okay. At best. If you look at really, really detailed studies of people who've had cardiac arrest, almost all of them have some fuzziness in the brain. Doesn't mean you're going to be a vegetable, but certainly you will have some degree of brain injury. Okay, whether or not that's going to be long lasting or not, it just depends on the circumstance. Okay, so what you noticed in Damar Hamlin's situations, they jumped on it pretty quickly. I remember saying to myself when that was happening that, it would be nice if the players and the referees, this is before we knew that he was going to survive, recognized it immediately and jumped on him and started doing CPR, because then you don't have that time for all those trainers and people to run out on the field. But they did. And thank God they did. They started the CPR. They ended up getting him the tube down his throat so they could deliver oxygen to him. And they continued that until they were able to restore normal heart rhythm and function. Okay. So CPR is very important. Okay. And stop right here just to give a few more shout outs and see some people checking in. Sister Queen, how you doing? My man, how's Mark doing? Tell him I said hello. Mark Hayes is in the house. Tabitha, how you doing? Tucker, hey, Jackie Williams, how you doing? Ken in Missouri, good to see you. Donna Owens, how you doing? Good friend there. Let's see here. I don't know how to scroll this thing on Instagram, but oh well, it's all good. So what happens to someone after this happens? What next? Okay, what next? All right. So you get this person, you get the airway, you get them intubated, you get the heart going again. What happens next? Okay. There's a lot of really exciting stuff that has occurred over the last 3 or 4 years, particularly during the COVID era, because some really advanced things that you can do. But let's start with the basics. Okay. So first and foremost, you want to basically support the patient. You want to make sure you can normalize the blood pressure. If it's low, you may require, the heart's been stunned. It may not be beating as well. You may want to put the patient on some medicines to support the heart, support the blood pressure. Make sure you have adequate vascular volume. Give them IV fluids. You got the tube in. Make sure that they're getting oxygen, et cetera, et cetera. So it's kind of the generalized support for the circulatory system, okay, to deliver oxygen fluid to the entire body. So you want to basically do that, because what you want to try to prevent is that shock state to kick in, where essentially you're not getting adequate blood flow to your organs. That kicks in a whole nother layer of cycle of negative things that occurs. Okay. So you get to the hospital. What next? All right. So clearly one of the things that and then next you get them to the hospital, you want to get, you get lab work and things like that to make sure that, the electrolytes, potassium, sodium, magnesium, calcium, all those things are in order. Okay. You want to check the actual oxygen content in the blood. You want to check and see if there's too much acid in the blood, because there's been a period of time where there's been no blood flow. Cells can begin to die, create acid. That's called acidosis. You want to correct that. So you want to, again, still part of that whole process of just sort of putting it all together. Okay. Then, of course, they're going to come in. All of you, or not all of you, but all of you are pretty familiar with the EKG. But if you've ever had one, or had to go to the ER for this, that's almost the first thing they do is plop that EKG on you. Why do they do that? Because in an acute setting, meaning it's happening now, okay, the EKG is very, very sensitive at picking up a heart attack, which is another cause potentially of sudden cardiac death or an abnormal rhythm of the heart, okay? So they do that EKG to see what that looks like, because if the person is having a heart attack, you'll see changes that indicate that, okay? And if that is the case, and you think the patient is having a heart attack, then it's straight to the cardiac catheterization lab, okay? Put the catheters up there and see if you can now open that artery up with a stent, okay? That's sort of the cardiac arrest related to a heart attack. Let's say it's not, okay? Say in this case, if we're talking about Commotio Cordis, no heart attack, okay? EKG looks normal now, okay? Kind of take a step back. Okay, good. Get the patient stabilized, get the blood pressure, get the patient out of this stunned myocardial state. Echocardiogram, ultrasound, rub some jelly around the heart. You can actually see the heart chambers, okay? See if the heart chambers are moving, okay? See if there's any leakage from the valves. Another condition, aortic dissection, okay, can lead to a lack of blood flow into the coronary arteries, okay? That's a torn blood vessel on top of the heart. Honestly, when I saw him go down, I was like, oh my goodness, I wonder if he's got an aneurysm and had an aortic dissection and now has bleeding around the heart causing compression of the heart or tamponade. Okay. That's what went through my head when I saw that. I was like, oh boy, did he just tear his aorta, or did that impact tear his aorta? Topic for another day, another conversation. So when we got this patient now in the ER, we're evaluating. Let's assume if it's heart attack, we're going to cath lab, we're going to open that artery up, and then we're going to continue that whole process afterwards, okay, of taking care of the patient. And then if it is a heart attack and there has been a significant period of time where the patient has had no blood flow to the brain, then you can put in what we call a cooling catheter. Okay, I'm going to stop right there because I need to get back to what else is going on in the ER. So no heart attack. Now we got the ultrasound. We see all the heart chambers. Everything looks good. Okay. Next thing you may want to do, okay, in that emergency situation, all right, CAT scan. Okay. In this case, because you're dealing with a young, healthy person who otherwise I would assume has no other medical problems if he's playing NFL football, scanning. Okay. That would start with a CT scan of the head. You can have an intracranial catastrophe like a bleed in your brain or ruptured aneurysm that can lead to a cardiac arrest. Okay. So head scan the chest, scan the abdomen, chest, head to chest, probably most important, abdomen as well. And basically you're just looking for any kind of abnormal condition or something that could have led to this. Okay. Or something, quite frankly, unrelated to the heart that may have come about during that period of time, either as a result of the impact or, quite frankly, before the R was already pre-existing and the impact just made it worse. Okay, precipitated something. All right, so CT scanning. All right, oftentimes in a situation where it just happens like that, there's no, in the CT of the head, unless there's bleeding, it's not sensitive enough to really pick up a stroke or something like that. Okay, it's just kind of a screening test. Now, some of those other things I talked about, vascular problems in the chest, blood around the heart, aortic dissection, those things you can see on that CAT scan. So it's important to do that. All right. Then a decision has to be made from a neurologic perspective. All right. All of this stuff is, again, you're trying to support the brain and all the other vital organs, as well as get the heart back into a normal cardiac rhythm and normal pumping, normal support of the bodily functions. Okay. So let's assume all of that looks good. We still got this person here who's had cardiac arrest. All right. Into the ICU. One of the things that we can do, and we do this a lot nowadays because the data is pretty compelling, is assuming now the heart is doing okay, we can put a cooling catheter in through our artery in the leg. Okay, what does that do? It actually cools the blood temperature down several degrees. What does cooling the body temperature down do? It lowers the body's metabolism, prevents, remember I talked about the acidosis, prevents that buildup of acidosis, all right, and it also prevents cell death. Okay, so what organ again is most sensitive to that? The brain. Cool the brain down, and you can delay cell death significantly. I've done this kind of study when I was in the lab in the mid-90s at Emory, looking at how fast brain cells will die. And can you preserve that with doing various things? In fact, our study at that time showed that we could do that. We could cool the brain. This is in animals, of course, cool the brain down to about 18 degrees and then restore the function back to normal for a period of time and then test it. And you can actually see that the genetic thing that kicks in for cells to die is actually protected because you're cooling it down. So we can now put in a cooling catheter, so where we literally put a catheter in, run the blood through the machine, cool the body temperature down, lowers metabolism, reduces cell death. Okay, that's one of the more advanced techniques. Okay, now let's assume that this was a heart attack. The heart's not working very well. Okay, so now you've got to support the heart. Okay, and whether it's a heart attack or whether it was just basically whatever that caused this heart not to function very well, you can even move on to even a more advanced technique than just cooling, which is called extracorporeal membrane oxygenation. Essentially, that's what I do in my patients every day when I'm operating is cardiopulmonary bypass, but you do it at the bedside, okay? With smaller catheters going in through the leg, you can put them in through the arteries and things in the chest, if you are up in the upper chest, if you want to do that. It's called extracorporeal membrane oxygenation. All right. That has the ability not only to support the heart, but you're also able to put oxygen in. Remember, it says ECMO, extracorporeal membrane oxygenation. So we're giving oxygen at a really high concentration. So in the case, for example, if the lungs have been affected by this and you're not able to get adequate oxygen through the endotracheal tube, then now you have the support of this ECMO system that's basically doing the work of the heart and lungs. Okay. We use that extensively during COVID. And in fact, the data suggests that it was highly effective in treating patients with COVID when they were basically at the point where the lungs were no longer adequate to deliver oxygen. Okay. So extracorporeal membrane oxygenation. Okay. So in the case that somebody's had a heart attack, you've gone and done that heart catheterization. All right. And you looked at those arteries, they're fine. Let's just say they didn't have a heart attack. Then you have to make the decision that are you going to go and do a heart cath anyway? Was there something else going on there? Okay. That we need to make sure these arteries. Okay. Well, in today's, and this is a judgment call. I don't know what the doctors there decided to do. But in today's world, you don't necessarily have to do that. Certainly in a young, otherwise healthy person, you can actually do a cardiac CT angiogram and look at those arteries and all those structures very closely and tell if you get, and for to a high degree of certainty and sensitivity, detect if there's a problem. Okay. So you may not need a heart catheterization after that happens. Okay. So again, we're talking about a normal situation. Now, let's think about all those reasons we talked about why someone went into cardiac arrest. Congestive heart failure, heart attack, abnormal cardiac rhythm, some kind of infiltrative cardiomyopathy, whatever. Okay. Now you've got to start working on how do you treat those things. Okay. How do you treat whatever it is that caused it? Okay. And then not only that, how do you get the heart to a point where you can essentially, it can work on its own without any support. Okay. And then how do you get that person off the breathing tube and sort of back, doing the things that are normal? But still, you've got to go through all of the steps in terms of working that person up: brain, heart, lungs, kidneys, everything, to make sure that you've done a thorough evaluation. So whatever it is, it can be effectively treated. I mentioned twice here so far the hypertrophic cardiomyopathy, and that's where you get a thickening of the heart muscle just underneath the heart valve. Okay. And it can also be diffuse where the entire heart is thickened that way. But if you get that can create a number of physiologic things. In those cases, sometimes the patient may need a pacemaker, may need a defibrillator to stop the heart from going into an abnormal rhythm if it does, okay, if it's vulnerable to that. So a lot of things that need to be worked out. One of the things that determines that is what the heart looks like on those echoes and those scans, MRIs, or whatever else, other diagnostic tests you do, but also how well the heart muscle squeezes, okay? So a weak heart muscle that has an ejection fraction, meaning how much blood comes out of the heart with every beat, should be somewhere between 55-65%, a visual estimate, okay, of course. But if it starts to get down below 35%, okay, and you have, certain types of conditions, you may need to have a defibrillator, okay? All right, sometimes when the heart goes into or has these problems, the upper and lower chambers don't beat in sync. That may require a pacemaker to basically make the heart beat in sync. Okay, it may require biventricular pacing, where you not only is the heart beating out of sync, but even the lower chambers are out of sync. Okay, so you got this sort of to and fro kind of movement of the lower ventricles or the ventricles left and right. They're not moving together, and therefore the output is compromised. So you may want to do biventricular pacing, where the impulse is simultaneous in making both of those ventricles beat, the left and the right, beat in tandem. Okay, because of that's a better physiologic state for the body and for the heart. Okay. So a lot of things need to be done to evaluate and to basically try to figure out what happened here. Okay. And then how are we going to treat it? Okay. Enough on that. What about the outcome? There's differences here. People who have a cardiac arrest in the hospital, like I described with the patient, with my good friend and former teacher, Joe Craver, people who have that problem in the hospital have a little higher survival rate. 60% of people in that situation, maybe plus, will survive, okay, at least for a year, Okay. But if you have a cardiac arrest outside of the hospital, okay, your long-term, basically just surviving that event depends upon what environment you're in. You just imagine that happens somewhere where nobody knows CPR and it takes EMS 15, 20 minutes to get there. Okay. That's a problem. Okay. That's why it's so important for all of you all to have some basic understanding of how to do CPR. It's very important. Okay. You could save a life. So out of hospital cardiac arrest. Okay. The goal is to get them to the hospital, because if you get them back and you get them to the hospital, essentially you can almost equalize the outcome, meaning that 60% of those people will survive. Okay. So oftentimes, we get these reports and people come in and they had a cardiac arrest out of the hospital, and then we get them to the hospital. Oh, we don't know if they're going to, you don't know. But, depending on a lot of circumstances, it's probably good to err on the side of doing all you can, because until you can establish whether or not there is brain function, there's a whole bunch of tests that they can do, EEGs, somatosensory function, and things like that, to tell what are your higher brain functions going to be. I said higher, meaning are you going to be able to see, feel, eat, touch, not paralyzed? The lower functions in terms of cognitive, who knows? Okay. But these are tests to just see if the brain function is still intact. Okay. So that's cardiac arrest. That's Commotio, Cordis, and cardiac arrest. All right. That is my kickoff, Dr. Coop, MD, for Heart Month. I'm glad you all joined me. Let me see if I got to do any more shout outs here. Jackie was the last one. Donna, Fatty S. Bear coming in on Facebook. Thank you so much for being here. Tanya Redding, Dennis, I appreciate it. You're always there. I love it. Thank you so much. And Instagram, I don't know how to scroll here. I think, well, maybe I am. Hey, B Cuts. Hey, Brian, what's up, cuz? Checking in from Louisiana. Erica Darnice, hey, how you doing? Hey, Dr. Lopez, how are you? Checking in. Greg, hey, what's going on? G876, I got you. Now, TKRD 1981, Chef Shambe, my chef. How you doing? Good to see you, Dr. Davis. All right. We got the whole crowd here today. So thank you all so much for joining me. This has been Hanging with Dr. Cooper, episode number 2. Hey, here's what I want you to do. Check it out. I really got an exciting show coming up in 2. Hey, Kim, how you doing? Thank you so much. One of my nurse friends, nurse extraordinaire, go back 25, 30 years. I just told your age. I told my age, didn't I? Hey, Courtney, how you doing? Sister-in-law, thank you for checking in. So 2 weeks. Hey, Lisa, how are you? Thank you so much. In 2 weeks, I got a really exciting program. We're going to be talking about, so many of you all, ask about this healthy lifestyle thing. I've got a treat for you. My good friend Rajitha Bomakanti, who's actually joining our company, Primo Health Partners, as our health coach, is going to really talk about, we're going to take a deep dive on how to do this beyond just the eat right and exercise that most of us doctors put out every day. So that's a really great show that's going to be coming up in 2 weeks. We're going to talk a little bit about the whole issue of lifestyle management in the context of your spiritual and mental well-being from a yogic and Ayurvedic perspective. So I'm really excited about that. Hey, David, how you doing, my friend? Good to see you. Thank you so much for joining in. Hey, look, I appreciate you all. You all have a fantastic Saturday. It's been Dr. Cooper, Hanging with Dr. Cooper, live from my little studio apartment in Kansas City. Go Chiefs. We're going to win this thing. I'll be back here next weekend. I got to leave for a minute next weekend for the Super Bowl to hang out with the people here in good old Kansas City. Hey, mother-in-law Bessie Webb, how you doing? For checking in. Thank you so much. We will see you all in a couple of weeks for our next Hanging with Dr. Cooper show. And I thank you so much for being here. Check me out, drcoopmd.com, primohealthpartners.com. All you people out there trying to lose that weight, we got you covered. Okay. We got a lot of other things too, services. So we'll be getting into that a little bit later. You all take care. Have a fantastic Saturday. Love you guys. There's nothing you can do about it. Take care.